Hi, I'm Dr. Diana Glasser. I'm a market medical director in California, and I'd like to share a story of one of my patients. The other day I was on call. I was just arriving into the hospital. It was around 7 a.m. I was receiving sign out from the outgoing doctor, and the nurses called saying that there was a patient who had arrived. She was a multiparous patient, meaning she had had multiple vaginal deliveries in the past. She didn't have a doctor there and she'd come in with contractions and she was very uncomfortable. So I went to see the patient. I introduced myself and I couldn't really get a history out of her because she was in so much pain and really wanted an epidural. And since I know these patients tend to deliver quickly, I just told her, let me just go get the anesthesiologist so we can get you comfortable. I left the room. I went to tell the nurses to get the anesthesiologist and I put in orders, admission orders for the patient. While I was doing that, the receptionist from L&D called me and she said, there's an emergency in your patient's room, please come. So I dropped everything, I run over there, and when I walked in, the patient was on all fours on her bed, and the nurse was just finishing up putting in an IV on her, and the baby's umbilical cord was on the bed. It was completely projecting out of her body. So I quickly put gloves on, I checked her, and I realized that she was a footling breech, meaning the baby's foot was in the vagina. So I grabbed the umbilical cord and I tried to reintroduce it into the uterus. She had not gotten her epidural, so she was in a lot of pain and was resisting my exam. I quickly told the nurses, please just take us to the operating room. I jumped on the patient's bed and tried to hold the umbilical cord as close to the baby as I could, and we rolled into one of the operating rooms. Since there was a case to start at 7:30, we bumped that case. We took that OR, which was ready to go, and the anesthesiologist was ready to go. So we gave her general anesthesia and quickly prepped her. And the doctor who had the scheduled case actually assisted me in doing the patient's surgery. The patient was 300 pounds. It was her first C-section, so that made it easy, but we did struggle a little bit with the patient's body habitus. We were lucky. The baby did very well. The NICU was there. APGARs were excellent, and mom did very well also. She did have a little bit more bleeding than we would have liked, but she didn't need a blood transfusion. Her vital signs were stable throughout, so we had a great outcome. So this is one of the values of OBHG, having an OBGYN in-house for all of these emergencies that will inevitably happen in a labor unit is crucial. Also, it's a peace of mind for the community doctors to know that we are there to stabilize their patients when they're home, and they don't have to rush into the hospital because we'll take care of their patient while they get there and we'll stabilize her and the baby. So all of this makes the OBHG program an excellent program for every hospital.